Hi, I'm Dr. Jack West, and I'm an associate clinical professor in medical oncology at the City of Hope Comprehensive Cancer Center in the Los Angeles area. Over the last 5 to 10 years, we've had a growing number of exceptional responders with advanced non-small cell lung cancer, so much so that we've started to debate amongst ourselves whether we can realistically talk about some of these patients being cured. And while we haven't settled that debate, it's great to be able to actually ask that question. We've had more experience for now a couple of decades with targeted therapies, and we know that there are many patients who can live for years routinely if they respond well to targeted therapy. And that may be especially true if they have very minimal disease and also get local therapy for whatever visible disease is left, something like stereotactic radiation. But to me, one of the most memorable cases that I can speak to is the first patient who I treated with immunotherapy who was on the Checkmate 017 trial, which was a second line trial of nivolumab versus docetaxel chemotherapy as second line treatment in patients with squamous histology lung cancer. This patient, lovely person who unfortunately had a very nasty bone-directed disease, became very symptomatic with her bone metastases, a lot of pain requiring ongoing pain medication, and also, unfortunately, progressing right through first-line chemotherapy quickly. She was on escalating pain medication, and her performance status was worsening over time, so much so that we were considering whether it would be necessary to transition to hospice as the next treatment approach, and certainly would have if she had progressed on this trial. She went on the study of nivolumab versus docetaxel. She was assigned to nivolumab, and she and her husband reported that her pain was improving significantly within the first few days after that first infusion. So much so that I wondered if it was some placebo effect, just because I did not expect to have a patient respond so quickly to immunotherapy based on the limited amount we knew at that time. But she continued to improve, and her first scan showed a dramatic improvement, and her next scan showed another ongoing improvement. And she continued to do remarkably well clinically and radiographically. We continued her on nivolumab for a couple of years and eventually decided to stop it because she was having increasing knee pain that we suspected was a side effect that was cumulative from immunotherapy. And we did a PET CT on her that showed that while there was a residual abnormality in her chest, there was no PET uptake there. She decided to stop nivolumab, and we've continued to follow her regularly. And I've been delighted to find that every visit is a cause for celebration. She's now 6 years out, 7 years out, and has no evidence of disease, lives a very full life, and remains gratified every day, as I do, with the response she's had. We can't know that she's truly cured, but in my mind, I think we've really redefined what's possible for patients with advanced non-small cell metastatic disease, a setting that we used to routinely tell people, unfortunately, categorically was essentially incurable. And I think that we are revisiting some of these old truisms because we're now seeing what's possible, and that there are patients both with targeted therapy benefits and immunotherapy benefits who are living for years and years extremely well, potentially even cured of their disease, but certainly redefining how well people can do with advanced non-small cell.
That was great. Exactly what we're looking for. Those kind of stories are so inspirational for patients. Thank you so much. It was a pleasure meeting with you today, and we appreciate your time.
Can I just do, I don't feel like I emphasized the Pembro monotherapy enough for the question about chemo Pembro versus Pembro.
Okay.
So I'm just going to redo that. And You can pick whichever one you guys like more, but
Sure, sure.
we have 20 minutes left in the
Yeah,
time.
absolutely.
Digital's cheap. Okay.
Okay, so the question was, how do you decide whether to favor immunotherapy alone or chemoimmuno for patients with advanced non-small cell lung cancer and high PD-L1 expression?
For patients with advanced non-small cell lung cancer and high tumor PD-L1 expression, we have arguably several competing standards. We have pembrolizumab monotherapy, which we've been using pretty routinely since the fall of 2016, when the original presentation of the Keynote-024 trial was done at ESMO in 2016, followed very quickly by an FDA approval for this. And subsequent follow-up data have shown that the survival benefit and all of the efficacy benefits seen with pembrolizumab have held up very well over time. We also have more recent studies and approvals of various chemo-immunotherapy combinations, such as chemo and pembro from the Keynote 189 and Keynote 024 trials. There are chemo with atezolizumab from Empower 130, chemo bev atezo from Empower 150, Nivo Ipi, even Nivo Ipi with chemotherapy based on the Checkmate 9 LA trial. So these studies have all beaten chemotherapy alone, as has pembrolizumab monotherapy. Well, how do you choose? We don't want to overtreat patients who don't need the chemotherapy, and we don't want to undertreat patients who do. And so when I see a patient in this setting, I really individualize for them. My sense is that most of these patients are appropriate candidates for pembrolizumab monotherapy, but a significant minority, and I think it's entirely a judgment of what that group is, I would favor chemo and pembro, say, for. And so I would, in some patients, choose carbo, pemetrexed, pembrolizumab if they have a non-squamous histology, or carbo, paclitaxel, or nab-paclitaxel with pembro if they have squamous histology, specifically for patients in whom I'm not confident that if their cancer progresses in that first couple or 3 cycles of pembrolizumab monotherapy, their performance status wouldn't decline, and they might not be as good a candidate to tolerate chemotherapy in the second-line setting. And that might be because their performance status starts off as compromised. They're very symptomatic from their disease. They have a tempo that is very rapid for their cancer, such as their cancer is leading them to have more pain and weight loss from one visit to the next in my initial visits with them. Or their scans show that they have a very high burden of cancer, not tumor mutational burden, but actual amount of cancer, the extent of metastatic burden on their imaging. Or if they have scans, maybe there's a clear difference between their initial CAT scan in the ER that led to the start of their workup and their PET CT that ended their screening, their staging, and it shows a marked worsening in 3 or 4 weeks. To me, these are all indications that this patient may not have the luxury of time to stretch out the immunotherapy and the chemotherapy, and we can't guess wrong. We need to front load. We need to give the patient every opportunity in the beginning to get control over this cancer, because we may not get a second shot on goal. It's important also to recognize that while patients can do remarkably well for years and years on immunotherapy alone, if they're fortunate, about half the patients who start with immunotherapy, even in the high PD-L1 group, don't show a response. And so we can't presume that that's going to be the case. And so I prefer to give the immunotherapy alone, generally pembro monotherapy, to patients who have favorable features that lead me to think they could benefit and not need chemotherapy, maybe for years, possibly even never. If I have doubt about their ability to have the same or very comparable performance status if they progress through the first line pembrolizumab, I'm going to err on the side of favoring chemoimmunotherapy.